Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation, Current Concepts in the Management of Shoulder Arthritis, presented by Dr. John Costouros, orthopedic surgeon with the Institute for Joint Restoration and Research at Washington Hospital Healthcare System. Dr. Costouros is a shoulder specialist serving patients in the Bay Area and beyond. Dr. Costouros has excelled in his field by providing the very latest advancements in the diagnosis and treatment of shoulder disorders. He completed his fellowship at Harvard Medical School of Shoulder and Elbow Surgery and is board certified with the American Board of Orthopedic Sports Medicine and the American Board of Orthopedic Surgery. Please welcome Dr. Costouros.
Welcome, everyone. It's a real pleasure to be back and speaking with you for the next 30 minutes or so on the current management of shoulder arthritis. It's a topic near and dear to me, as I am one of the few people out there who has devoted their entire career, now 20 plus years, exclusively to the shoulder and the comprehensive treatment of shoulder disorders. This begins with things like rotator cuff tears, sports injuries, instability problems, fractures and trauma, failed prior surgeries, arthritis, which will be the focus of today's presentation. And for advanced cases of arthritis, sometimes joint replacement is indicated and required, but frequently other treatments that are less invasive, like arthroscopic surgery and other open techniques, can be considered prior to joint replacement. The overview of today's presentation will begin with some information about basic anatomy of the shoulder, the clinical evaluation of patients with shoulder pain, the various forms of shoulder arthritis which we encounter, treatment, new technologies, and future directions. Now, the shoulder is really an amazing joint. It has the widest range of motion of any joint in the body, and it has inherent instability, which makes it prone to certain injuries which are unique. This is looking from the back of the shoulder at the rotator cuff complex, which envelopes the upper arm bone, the humerus, like a swim cap. And these are the various muscles that allow you to raise the arm and rotate and do various things, reach behind your back. And so they encircle the head, as we see here, looking from front to back. Now, as we get deeper into the shoulder, beyond the rotator cuff tendons and musculature, we have a capsule. Capsules envelope all joints of the body, and they help contain joint fluid, which lubricates the joint and allows for free and smooth gliding of the cartilage on both sides of the joint. Inside of the joint, we have the ball and the socket. Here is the socket. We call that the glenoid. And around the glenoid, which is very small, kind of like a golf tee, there is a circular soft tissue called the labrum, which imparts stability to the shoulder joint. We also have ligaments, which are really thickenings of the capsule, which allow for certain types of stability. These can become injured. And then we have one part of the biceps complex called the long head, which is depicted in pink there, which attaches to the top of the labrum. That can be prone to unique injuries. And then the shoulder itself, which is really four joints, is depicted here. We have the glenohumeral joint, which is what I was describing earlier. This is where most of the motion of the shoulder comes from. We have the scapulothoracic joint, which is the shoulder blade, which you can feel on the back, which glides over the rib cage. The acromioclavicular joint, which is where the collarbone comes around, and that's depicted over here. And then the sternoclavicular joint, which is where the other end of the clavicle articulates with the breastbone, or the sternum, as we say medically. And so these are the four joints that comprise shoulder. Now, 2/3 of your motion comes from the glenohumeral joint, the ball and the socket joint, where most of the injuries occur and most of the arthritis occurs. And then 1/3 of your motion comes from the shoulder blade gliding over the rib cage. So when someone has a lot of arthritis or stiffness in the glenohumeral joint, a lot of the motion is compensatory coming from the scapulothoracic joint. So when we evaluate a shoulder and really any problem in orthopedics, we first begin by taking a history. What are your symptoms? Where does it hurt? This gives us important information. And then we go through a stepwise approach, including examination, obtaining imaging, usually x-rays to start, and then advanced imaging like MRI or CT. And then we consider the various forms of treatment. Now, one of the things which is very unique to the shoulder is outside of shoulder problems, there are pain patterns which can refer to the shoulder. And so cardiac disease like ischemia can refer pain to the left shoulder. Gallbladder disease and gallstones can refer pain to the right shoulder. And as you see here, there are various elements that we need to consider and be comprehensive about before we just get tunnel vision and jump into treating shoulder problems. History and age is an important clue for us. Instability problems tend to affect younger patients. Adhesive capsulitis or frozen shoulder, usually women, patients over the age of 30. Rotator cuff tears, which are the most common shoulder pathology that I see, age greater than 40, and then arthritis as we get older, obviously, 50 and beyond typically. So what do patients complain about who have shoulder arthritis? It's usually a dull, constant pain, sometimes sharp in certain positions of the arm. Patients have night pain, they have trouble sleeping on their shoulder if they're side sleepers, or maybe bringing the arm out to the side due to loss of motion. They wake up when they roll over. And then there's functional problems. They can't reach behind their back or out to the side. They have difficulty doing their hair, and their mobility gradually gets worse over time. They can't work out, they can't swim, they can't throw a ball, play golf, do things that they used to do without even thinking about it. So when we examine the shoulder, we first look. There's a lot that we can glean just from the appearance of the skin and other structures. We push on things, that's called palpation. We check motion, strength, and then perform certain provocative tests. And so all these elements can give us a clue as to the diagnosis. Now granted, you can't feel and push everything deep in the shoulder, but there are other things more superficial which can provide good information. This is a patient obviously who has loss of motion on one side. And so then we obtain x-rays. And so this x-ray looks from front to back at the shoulder joint, the ball, and the socket, which is right over here. We have the acromioclavicular joint, which I alluded to earlier here. And this is looking from another angle. This is called the axillary view. And so what we're really looking at is alignment, joint space, other elements like that. So compare that x-ray to the x-ray that I just brought out here, where the joint space is very narrowed. There are bone spurs which have formed here. There's whiteness. We call this subchondral sclerosis. That's how bone reacts to loss of cartilage. It lays down more bone and more calcium. And then on the axillary view here, the bone joint space is completely gone and the joint is starting to shift out the back. We call that subluxation. Here's an MRI. This gives us more detailed information where you get into a magnet. And this gives us the most detailed information about the soft tissue architecture of the shoulder. And so we're looking at tendons. Here we have a patient who has a rotator cuff tear. And here we see the rotator cuff muscles from a different angle. And so this is very useful information for us. The CAT scan is another diagnostic tool that we use. This gives us very important information about the bony anatomy and something that we tend to routinely get when we're considering shoulder replacement surgery. And the reason for that is that it gives us information that we cannot obtain from the MRI. And furthermore, some of the latest technology uses software that relies on the information from the CAT scan. And so we live in an age of augmented and virtual reality and robotic things. And so precision medicine is here and it's here to stay. And I've been really a pioneer in the development of some of these technologies over the past 20 years. Here we see a surgical plan where we can virtually perform the surgery prior to getting into the operating room and generate instruments to help us when we get into the operating room by wearing special goggles which can impart a projection onto not only the surgical plan but onto the patient's actual anatomy to allow us to execute our plan with greater precision. And greater precision means better results. And so here's an example of a video from surgery. And if we could turn the sound on this if possible, it's basically me calibrating a surgical instrument which is connecting to the computer to allow me to execute the surgical plan in a live setting. Now, what is arthritis? Arthritis is loss of cartilage. We have cartilage on all of our joints. And so arthritis is the loss of cartilage, but also it's the loss of compliance of the capsule of the joint. So it's not just about replacing the cartilage with metal or plastic, it's about soft tissue balancing and releasing some of the scar tissue. And with shoulders especially, that's critically important. There are various forms of arthritis. There's primary arthritis, which is just wear and tear, degenerative arthritis. There's secondary arthritis, which is secondary to trauma, to a prior stabilization procedure, for example, in the setting of rotator cuff tears that can accelerate arthritis, and then some anesthetics, which we don't use anymore, can cause cartilage damage. There's arthritis caused by gout, and there's arthritis caused by inflammatory conditions like rheumatoid arthritis or psoriatic arthritis. Now, with primary degenerative arthritis, there are certain typical features like I showed earlier. There's joint space narrowing, there's bone spur formation, and so these are things that I can recognize just by looking at the x-ray. In contrast, inflammatory arthritis paints a very different picture. There's more symmetric loss of joint space, not as many bone spurs, and then bone loss or bone erosion is very typical with these types of arthritis. And that can create some challenging over time when we try to implant prosthetics when there's been a lot of bone loss. Rotator cuff tearing is common with psoriatic and rheumatoid arthritis. And as time goes on, when the rotator cuff is torn, as you can see here, the ball is migrating upwards. And that's because the typical tendons that keep the joint in space connected to the glenoid is lost. And so the forces lead to upward migration. And in very severe cases, it looks like this. Now, thankfully, over time, a lot of the medications that are out there to treat inflammatory arthritis have gotten much better. We call these DMARDs, or disease-modifying anti-rheumatic agents. And so because of this, some of the severe bone loss issues that we used to encounter as orthopedic surgeons are less severe. But at the end of the day, sometimes surgery is really the only way to restore function and to eliminate pain. Other forms of arthritis are due to steroids, excess alcohol use, or trauma. We call this osteonecrosis, or literally death of bone. It leads to loss of blood supply, which supplies the area of the articular surface of cartilage, and so it has certain characteristic findings as we see there. So how do we treat arthritis? We begin with conservative elements, non-surgical, anti-inflammatories, Tylenol, Aleve, ibuprofen, those sorts of things, physical therapy. To a point, people can modify their activities. And for some people, this is enough to turn the needle in a positive direction, and they're satisfied. Sometimes we consider injections. Steroids can be considered. There's a lot of buzz about biologics out there in the media about things like stem cells and platelet-rich plasma. The reality is that in the shoulder, this has been studied, and so far we haven't seen a clear benefit in the peer-reviewed literature, but we continue to investigate these therapies very closely. In less severe cases of arthritis, arthroscopic treatment can be considered, and we basically can clean out some of the inflammatory mediators and other elements which can cause pain. But in more severe cases, joint replacement is required. This is what arthroscopy looks like. We have a camera, we have small portals, we can do a lot of our work minimally invasively, release scar tissue, treat some loose flaps of tissue which are part of the process, and patients can benefit. When do we consider arthroscopy? Sometimes patients are young or young at heart, high-risk patients that may not be a candidate for joint replacement, although even high-risk patients can be considered today. The technology and the science has evolved. Sometimes people just want in-and-out surgery, a faster recovery, and they're not interested in the 3 or 4 months that is needed for joint replacement. But the outcomes are less predictable. There is a trade-off to a degree. And again, this is really something that we reserve for more mild to moderate cases. Here's a patient who had the osteonecrosis from steroid use. He was only 28. The joint is highly damaged. And so here we used a less invasive joint replacement depicted here. This is a resurfacing hemiarthroplasty, we call it. And so this is post-operative x-rays of what that looks like. This patient did well for many years. Total shoulder arthroplasty is replacing both sides of the joint, which are typically arthritic. due to pain and loss of function from the various forms of arthritis that we talked about earlier. The requirement for a traditional shoulder replacement is having an intact rotator cuff complex. Otherwise, the shoulder replacement will not work well functionally and the components can loosen. This is actually a picture of the first shoulder replacement made by Dr. Payan back in 1893, made of rubber and platinum. It didn't last too long. This was done for tuberculosis of the shoulder. It eventually got infected. We didn't have good sterile techniques in those days, and a lot has evolved since then, believe it or not. Traditional modern-day shoulder replacement really became more popular in about the 1950s. In those days, the implants were very primitive. They didn't have many sizes. They didn't perform as well. Obviously, today things are much different. And so we have anatomic replacements. We have short stem replacements. We have hemiarthroplasties, which are half of the joint. And then we have reverse replacement, which I will talk to a little bit on the lower right there, where the ball and the socket are reversed. Here's a patient of mine that was featured on the front page of the San Francisco Chronicle about 15, 20 years ago, just bringing to light the popularity that has been growing of shoulder replacement, which is really life-changing. It is the fastest growing area of joint replacement over the past 20 years. Although you hear more about hips and knees, shoulder replacement is here to stay and growing. So here's the patient that I showed earlier with pain and stiffness, 65 years old. Here are his x-rays, bad arthritis. There's the CAT scan, and this is what the post-operative x-rays look like and the function after surgery. Very happy patient. In 2013, we began looking at less invasive methods of shoulder replacement. So I was the principal investigator of 3 FDA clinical trials looking at various devices here which have no stem going in the bone. Bone preserving, less invasive. We found that the patients recovered much more quickly. Surgery was less long, and many of these were done more and more as an outpatient procedure. So in the old days, people would stay in the hospital 3 to 4 days in the hospital after joint replacement. Now it's an outpatient procedure for the most part. And I was the only center in California to offer a new stemless reverse prosthesis. We completed that here at Washington, and the FDA is now looking at the data, and this will soon become an option for patients very soon to again benefit from faster recovery and less post-operative pain. Here's a patient who had a stemless anatomic prosthesis. Here are the post-op x-rays, and here's the function after surgery. Happy patient. So reverse replacement is something that is near and dear to me. I actually brought it to California in 2004 from Switzerland, where it was available in Europe for about 20 years prior. We had to go through the FDA and everything here in the United States. And so it works for patients who have a variety of more complex conditions of the shoulder where the rotator cuff is not there. So it helps to change the mechanics of the shoulder so that the deltoid muscle can elevate the arm. And so when I was at Stanford, I developed the outpatient shoulder replacement program there, and I've had a long history and track record of performing this particular procedure. These are some of the reasons why we do reverse replacement. And here's an example of a patient who is 70 with a large rotator cuff tear. The humerus is migrating upward, and so we see here some of the more advanced imaging, and this is this patient after a short stem reverse total shoulder who did very well. This was a retired nurse. Here's a fracture in an elderly patient with poor bone quality. Sometimes we can fix these fractures with plates and screws, and other times replacement is where to go. And so that was the case here. And we did a reverse replacement, and this patient did well as well. So looking forward, we live in the age of precision medicine, which is a medical model that proposes the customization of healthcare with medical decisions, treatments, practices, or products being tailored to the individual. It is data-driven, and we are looking more and more at individualized evidence-based medicine. And so this is a surgical plan which is specific to this particular patient that I alluded to earlier, where we can manipulate the implants virtually. And here's a video of a surgery. We have a 3D printed model which was generated to account for a lot of bone loss and deformity, use a specific guide tailored to this patient to allow us to use our instruments and prepare for shoulder replacement in a very precise fashion, which in the old days was really geared based on surgeon experience and eyeballing things to a degree. And so this is what shoulder replacement looks like. We're drilling and preparing the socket part, the glenoid, for implantation of a shoulder component. Those are trowel components. Here's what the bone looks like. Now we're putting cement into these various holes, and then we push in the plastic. And there you have it, precision medicine. So looking forward, virtual planning software is here to stay and evolving and improving. We alluded to augmented reality. I'm currently working in the development of robotic-assisted shoulder surgery, which has been present for knees and other areas, but not in the shoulder. So this will be coming soon. Tissue engineering, growth factors, and stem cells are still under development. So in summary, the shoulder is a complex joint. Arthritis affects all of us in varying degrees. Surgery can eliminate pain and motion loss if other methods fail, conservative methods. And sometimes it's the only method that's really going to give you a durable solution. Exciting new technologies and techniques are on the horizon. Thank you for your attention.
Thank you, Doctor. We do have some questions if you have a moment. We have, the first question is, what is the most common arthritic condition of the shoulder?
The most common arthritic condition is degenerative arthritis, or primary osteoarthritis, otherwise known as wear and tear, degenerative joint disease.
Okay, and our next question, what exercises should I avoid to reduce the risk of shoulder injury?
Well, we all live active lives, and physical activity has many benefits. So I don't like to limit patients. However, doing one thing over and over again, as you would imagine, can accelerate the development of arthritis. So let's say, for example, someone only does push-ups all the time, and they're bearing all their weight through excessive shear force through the shoulder, or just doing heavy bench press all the time. That can accelerate the development of arthritis. So I advise patients to cross-train, to focus on technique, and to perform different sorts of exercises that don't lead to the same part of the shoulder being impacted over and over again.
Okay, the next question we have is, if you have arthritis in your shoulder, will you necessarily need surgery?
Absolutely not. So the elements that contribute to the development of arthritis are, number one, your genetics. Number two, your diet. Number three, your activities. Sometimes it's just your vocation and things you can't get around that can accelerate wear and tear. There's trauma. Those sorts of things can accelerate or lead to the development of arthritis. And that's one part of it. The other part of it is what we see on X-ray. There are patients who have very severe arthritic changes on X-ray where functionally they're performing pretty well. They don't have a lot of pain. Their motion is not perfect but adequate. And so again, there's a vast spectrum of how this presents and what causes it. And as I indicated earlier, there are a lot of treatments that you can consider doing before you even get to surgery. But if surgery is something to consider, in 2023, the results are excellent. The anesthesia techniques have improved. The postoperative care has improved. The technology, as you saw a little glimpse of, has improved tremendously. So there are options out there.
Okay, and our last question is, if you're having shoulder pain, at what point should I contact my doctor?
I think that if you have a trauma and a sudden loss of function, it is important to see a specialist sooner than later. And the reason for that is some injuries, like a fracture, can go undiagnosed. Some things like a traumatic full-thickness tendon tear can go undiagnosed. And some of these types of injuries have a timeline where getting the appropriate treatment sooner is critically important. Other things, where if it just is insidious in onset and it's a little sore, it's okay, you didn't have a trauma, it's probably okay to wait on it for a little bit, try some rest, try some ice, try some anti-inflammatories, maybe check in with your primary care doctor first. But most of the time it never hurts if you have access to see a specialist to get right to the nitty-gritty and see exactly what's going on.
Okay, thank you, Dr. Costouros, for this insightful presentation and for answering our questions. This concludes our program, and thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.